We're going to get started. We'll be right on time. We have a very tight schedule. A very, very warm welcome to you all. We're thrilled to have such an incredible turnout. I think year over year we're getting more and more folks to come to the GRAPPA Symposium. We're absolutely delighted to be able to host this here at EADV and have you all here with us. I just have a few housekeeping slides and then we'll kick off our program. Just to say, including to my delightful friends, colleagues, and speakers in the front row, we have fairly tight timelines of about 10 minutes. So if you see me giving them dirty looks, that's because we're giving them the hook. And then at the very end, we have open Q&A, panel discussion, and we'll figure out some arrangement to have all of your friends here in the front answering questions in some format. So with that, let me just share a few items. Again, we're delighted to have this really tremendously full room. This is wonderful. I want to thank at the beginning and at the back end of the conference, Judy, who was in the room a moment ago. There she is in the back waving her hand for organizing this year over year. Really tremendous work, and we're grateful to have her here with us. A few background items. So we couldn't have any of these, the work that you'll see, a lot of the research is supported by, certainly our meetings and organization are supported by these incredible industry sponsors. I'm going to ask you, in fact, to give them a round of applause because we are very grateful to them for making this possible year over year. This is our agenda. Again, in the interest of time, we're going to cover a number of hot topics of great interest to GRAPPA stakeholders, so stay tuned. This is our current leadership structure board of directors. I'm delighted to be co-president with Dr. Artie Cavanaugh. Many of you may know him, rheumatologist. And you can see our group here. In fact, two of our speakers, Dr. April Armstrong, Dr. Laura Savage on the board here. And I think, I won't read this to you. It's a very vibrant organization doing a lot of collaborative work between the dermatology, rheumatology, and increasingly other specialty areas relevant to psoriatic disease space. If anyone's interested in learning more, is not part of GRAPPA, feel free to scan the QR code, get a little bit more information on what we do, where our meetings are. This is an interesting one for GRAPPA members. And available on the website is the slide library. This is a huge thanks to our young GRAPPA group. In fact, we'll hear from one of our young GRAPPA representatives in just a few moments. An incredible resource. This library has been curated, and it's iteratively updated over time. Available in 6 languages so far. There are several more coming. Variety of topics, and you quite literally can go through this huge library, pick which slide you want, and it builds a slide deck of this content that's really helpful for disseminating knowledge in local regions. So tremendous resource. Again, feel free to take a look at that. Also, mark your calendars. We have the 2026 annual meeting and trainee symposium, which will be in Lisboa in Portugal, July 9th to 11th. So keep that in mind. Okay, with that, I will introduce the first speaker. That's me. So that was easy. I'm delighted to be giving a very high level, very rapid, I won't be spending a lot of time here. I'm going to keep it very quick. But a high-level view of some psoriatic arthritis, interesting topics that have come up over the past year for a dermatology audience. Hopefully you find these interesting as well. It's just meant to be a little high-level update, and then I'll pass it on to better speakers than myself thereafter. So I'm Joe Marola. I'm a dermatologist and rheumatologist, chair of dermatology at UT Southwestern in Dallas. Again, and delighted to be with you all. These are my disclosures, and I already discussed the GRAPPA disclosure. So a busy slide. I might go ahead of this and come back, but I think one of the interesting studies that was presented at EULAR this past year, of note to the dermatologist, I think, as well, is the SPEED study. This was led by Laura Coates and colleagues in the UK. It's a look at early intervention to control disease, essentially looking at early intensive versus step-up therapy among a cohort of patients who have had no prior DMARDs, so really new to therapy, systemic therapy, and newly diagnosed psoriatic arthritis. And their definition of newly diagnosed was essentially within 2 years that they were capturing these patients. And it's sort of an enriched cohort that had at least one poor prognostic factor as listed there. So they had polyarthritis, elevated CRP, radiographic erosion, or elevation in their HAQ score, meaning they had impact on function. So the question here essentially was this, I'll keep it brief, but they had a new PSA cohort referral who either went into standard of care, being typically methotrexate, CSD-MARD, and then had stepwise therapy, right? So this is a sort of traditional rheumatologic approach to PSA. Start with one agent, move on to the second, eventually make their way to biologics to keep it simple. Another group who went on to combination DMARD therapy, and for those of you who have followed this, there was a study in the Lancet, I want to say maybe 2 years ago, that looked at combination CSD-MARD, for example, with methotrexate and leflunomide, that showed some benefit over methotrexate alone. So this was an arm looking at that combination traditional DMARD. And a third arm that looked at starting TNF early, okay, biologic therapy early. And there were two key time points, and then I'll cut to the chase, 24 weeks and 48 weeks. And the question was, did these patients show, was there value in either combination or early to biologic at those two time points? The endpoint here was a PASDAS endpoint, which I'll show you. So what were the results? At week 24, it turned out that both the combination CSD-MARD arm and the early TNF arm both showed statistically significantly better mean PASDAS scores than the standard step-up program. That was the first finding. However, at 48 weeks, the benefit was only maintained in the early TNF biologic group. Okay, so again, I won't go through all of this in the interest of time, but a little bit this supports some of the ACR guidelines that moved past oral systemic therapy to biologic, for example, in the treatment of PSA, and I think is an interesting concept when we think about how we might start to approach patients with early disease over time. You'll see themes at this meeting about early disease control in psoriasis with updates from the GUIDE study, among others, so stay tuned for that. There's a number of other exciting programs coming along. I don't have data for all of these. I'm going to share with you the APEX study. But these are several exciting studies coming out of the guselkumab program. As you may know, there's been some question about whether and how well IL-23 inhibitors might impact axial psoriatic arthritis. I don't have an answer for you yet, except to say that the STAR study is ongoing, and we hope to have data from that in the coming future. The Solstice study is a look at patients who have had an inadequate response essentially to TNF inhibitors and looking at efficacy of guselkumab in that population. The one that I want to focus on, however, is APEX. So this was, I think, a hot topic this year, and this was a dedicated study of guselkumab looking at inhibition of radiographic progression. Again, I won't go into this in great detail, but the idea here is, to date, at least in the US, we've had only 3 classes of medication that had shown inhibition of radiographic progression, which made it into their package insert and label in the US. Those were several TNF inhibitors, JAK inhibitors, and IL-17 inhibitors. We did not have that same label for our IL-23 P19 inhibitors, nor IL-12/23 inhibitors to date. And this concept of radiographic progression, I promise I won't read you this slide at high level, is just to say it's complicated. It's borrowed from rheumatoid arthritis, and it was modified as an endpoint to fit psoriatic arthritis. And in fact, what we see in most studies is that very small numbers of patients actually go on to progress, and it takes some time to see that progression. And it's pretty remarkable, in fact, that we're able to show inhibition of radiographic progression within the timeline of 6 months or a year. Most studies look at 16 to 24 weeks for these endpoints. So this is what I was trying to get to. So guselkumab, this is very important data for us, I think, in the rheumatology and especially in the dermatology space to understand how these mechanisms, and guselkumab specifically, is impacting our ability to inhibit radiographic progression, to inhibit erosion and damage in joints. What they were able to show in the study was that both the every 4-week as well as the every 8-week dosing was able to show inhibition of radiographic progression with regard to the different components that go into that score at each respective time point compared to placebo. So this was really a hot topic this past year. If anyone's interested in some more information about this whole concept, actually Alice and I wrote this review not long ago that looks at structural damage in psoriatic arthritis, pathogenesis, and some ongoing controversies. Okay, some other hot topics from the past year. Many of you may have seen this. If you haven't, this is important. This was some of the first phase 3 data of TYK2 inhibition in psoriatic arthritis. This was deucravacitinib for patients with active psoriatic arthritis. Again, in the interest of time, very standard trial design. You can see the 6 milligram once daily dose that's approved for psoriasis in the United States. There was also an active comparator arm, 30 milligram BID, standard dosing of apremilast. That was rather a safety reference arm. The take-home message was that they did meet their primary endpoint, the ACR20. You can also see the ACR50 and 70 data there, as well as what I also often like to highlight, the minimal disease activity data. About a quarter of patients were in minimal disease activity by week 16 on this drug. You can see some more modest placebo deltas there with a relatively high placebo rate in the ACR20 response of almost 40%, but indeed a positive study. And so this is one I wanted to highlight. No new safety events were reported in the PSA program. And then just a few highlights of things to come before I turn this over. So I think one thing that we're all excited about, and we'll be keeping an open eye for data, hopefully sooner than later, is the Be Bold study. So this is, for those who follow this field very closely, we have very little head-to-head data in psoriatic arthritis. Some of the little head-to-head data that we have, for example, was with IL-17 versus TNF inhibition in studies like the Spirit head-to-head study, the Exceed trial, with secukinumab. And so this is really the first look that we have at IL-17 versus IL-23 inhibition in patients with active psoriatic arthritis. You'll appreciate that it's a week 16 primary endpoint, and they will continue to look out to week 24. And you can also appreciate the primary endpoint is an ACR50 response, as well as many secondary endpoints, including some composite measures of interest to skin and joint disease. So stay tuned for that. I think the last two things I'll speak about are this molecule. So for those of you who have been following the Oruka program, there is a series of psoriasis and psoriatic arthritis facing molecules coming from this group that have looked at novel extended half-life of these monoclonal antibodies. Essentially, there's an FC portion alteration that harnesses the power of the FcRn, the neonatal Fc receptor, to extend their half-life, in simple terms. And to say that they have both a P19 IL-23 inhibitor as well as this IL-17AF inhibitor. And so, the interest here, I think, for psoriatic arthritis is to see a molecule that we know is very robust in, or a mechanism that's very robust in psoriatic arthritis, namely IL-17AF inhibition, but with an extended half-life, sort of offering the opportunity potentially to do once or twice yearly, for example, dosing of our patients with psoriatic arthritis. So stay tuned for that. I think that might be something of interest. And last 2 points, I think many of you will see this very exciting icotrokinra program, this oral targeted peptide of IL-23 receptor that has shown a lot of data. We'll have a lot of data here at this meeting for psoriasis. I highlighted, however, there's also an ongoing program in psoriatic arthritis, which will be exciting to have an oral targeted peptide, first oral targeted peptide of its kind, potentially for psoriatic arthritis. So stay tuned for that. And lastly, I think another theme you'll see at the meeting, and one that we're all quite excited about, are not only combination therapy approaches, but really novel approaches to a more comprehensive look at psoriatic disease treatment. So not only psoriasis or psoriatic arthritis, but also dealing with a key comorbidity of disease, in this case with obesity. And I don't have time to go into great detail, nor do I have to, because our own Dr. Ken Gordon is going to give us a deep dive into GLP-1 agonists and psoriatic arthritis and incretins in just a moment, so stay tuned. But just to say that this is an exciting study, the Together PSA study that's looking at an arm of IL-17A plus incretin GLP-1 GIP receptor agonist, rather, versus IL-17 alone, with a primary endpoint at 36 weeks in a simultaneous achievement endpoint of ACR 50 and weight reduction. So a lot of exciting things to come. And I think I'm more or less on time. I thank you for your attention. And with that, tour de force, rapid pressured speech, I will turn over the podium to a friend and colleague, Dr. Ken Gordon. Ken comes from the Medical College of Wisconsin. Hopefully he's well known to you all. And we're grateful to have him here with us. Thank you, Ken.
Thank you very much, Joe. And I always find it interesting when I speak at GRAPPA Symposia that I get topics for things I have really not done a lot of work on over time. And so it's always a new talk. So thank you very much. And so the question is, do incretins really help psoriasis and help inflammatory disease? And the answer is, I have no idea. Thank you very much. It's been a pleasure speaking today. But the real question is, there's a Winston Churchill quote in here somewhere. There's been more written on this subject over the last couple of years with less data by more people than any subject I can think of. What I'm going to try to do is summarize a little bit of what is known, and at the end try to say what are the questions that we really do need to ask. So here are my conflicts of interest, and they're multiple. So I work in the state of Wisconsin in the United States, and if you know anything about the state of Wisconsin, this gentleman shows how much we need to use GLP-1 agonists in the treatment of psoriasis. This is a standard patient in Wisconsin, actually probably a little thin, but basically psoriasis and obesity have been associated for many, many years, and as well as the comorbid diseases in psoriasis. So the question is, do GLP agonists help psoriasis? And in looking at the literature here, I had to make some decisions to get this in a 10-minute talk. I'm going to try to discuss the impact of inflammatory conditions of the medications on inflammatory conditions in psoriasis. I'm not going to talk about the generalized health benefits of using incretins for people with obesity and diabetes. I think those are well established. We can all agree on those. And that includes patients with psoriasis, where there might be significant value in patients like my patient in treating them regardless of the impact on the disease. I'm also going to ignore joint disease. If you look at the literature in PSA, there's a lot of complexity associated with the impact of just weight loss on joint disease and on pain and things of that sort that I actually think complicate the question that you can't really discuss in a 10-minute question. So I'm going to try to stick with psoriasis rather than psoriatic arthritis. And I'm going to try to stick to the data. And I'm really going to try to avoid a couple things. One, I'm going to try to emphasize that there is massive publication bias in this area. If you look at small cases and small case series, you're going to see the ones that are positive. And a number of us have worked for years reviewing all the data in the AAD and the EADV in psoriasis over years, and we've seen weight loss things. We've seen studies that got shown, or small case reports where things didn't work, bariatric surgery, things like that, that never made it to the literature. And so I think there's a massive positive publication bias that we have to take into account when we're looking at studies of GLP-1s right now. There are two questions that I think need to be viewed as: is the impact of GLPs the impact of weight loss by itself on psoriasis, or is there an independent aspect of using these medications regardless of weight loss? And that's going to be something that's going to be very difficult to tease out. And it's not something that I think we have the data to discuss right now. I think that study that Joe pointed out before if you look at some of the endpoints that they're studying, they're looking at a combined endpoint of weight loss and psoriasis benefit. To me, actually, the most interesting patients were the patients who look at their psoriasis when they don't have benefit in weight loss. Because I think in that small group of people who does not have weight loss, you can actually see, is there something from the drug that's impacting the disease? And so that's really the questions that we have to answer. So much of the weight loss, there is, I think, quite a bit of clarity that weight loss does impact response to therapy. So this is one of the studies that came out a number of years ago. It's representative of multiple studies where patients were given what is basically, to me, a starvation diet. 800 calories a day, going up to 1,000 calories a day. In my eating habits, that's probably half of breakfast. And so you saw in those patients who were given that versus a normal diet that patients lost weight and their psoriasis improved too. Now I would say if you look at the mean changes in here, you see a change in positive about 2.5. Interestingly enough, these were obese patients. Their positive at baseline was only about 4 to 5. And so these patients didn't have severe impact. So in 16 weeks, using a sort of what's a relatively slow intervention, the responses were relatively good. So weight loss in patients who are being treated with therapy, some of these patients were on systemic therapy, some on topical therapy, was part of something that could be shown. And there were a number of meta-analyses looking at studies, looking at weight loss, that all sort of trend in the same direction. Some of these aren't really big effects, but the patients generally all will have some impact of weight loss on improvement in psoriasis. There was a group that got together saying treatment of obesity may improve the efficacy of psoriasis therapies. And I think that's exactly right. There's very little that is just treatment of psoriasis with weight loss on patients who are not on other therapies, which is really what you would need to be able to make this determination. I actually thought I'd come up here today and say, okay, here's the mechanism immunologically by which GLPs might improve psoriasis. And then I went through it. There are a gazillion in vitro studies looking, and that's the exact number, by the way, a gazillion, in looking at GLP effects on inflammation. Basically, there's a whole literature on keratinocytes, even though, interestingly enough, GLP receptors aren't on keratinocytes in vivo. And so all this in vitro work, I can't differentiate what are the exact mechanisms. Basically, fat is a pro-inflammatory tissue. GLPs might have significant effects on inflammation in particular, but I'm not going to try to explain the mechanism because I don't think we can. We don't have that kind of specificity yet. There have been some studies that are a little bit better in the past looking at GLP-1 agonists. And this is liraglutide, which was one of the first ones that was approved for diabetes. It's been used around the world. This is looking at a small study looking at liraglutide in diabetic patients who are not on therapy for their psoriasis. And their positives varied. You had some people with quite severe disease, some with milder disease, but in generally, the patients improved with their change in BMI as well. So this is in diabetic patients. A similar study was done in obese, insulin-sensitive patients. So these are theoretically obese patients who have normal insulin sensitivity, would not be classified as diabetic, in which case the data did not show in what's a relatively small study an improvement in a placebo-controlled trial. So the other question is there something about patients who are actively diabetic? Diabetes actually is a pro-inflammatory state as well that might be different from the patients who are non-diabetic. This was another study using liraglutide, which is actually the one that's sort of quoted as saying, this shows that the GLPs are the most effective. But it's really fascinating. This actually shows the greatest magnitude of response of any of the trials with GLP-1s. But the patients were actually started on acitretin as well in this choice in this publication. Acitretin be a kind of interesting choice, but that was what was done. And in fact, he showed the highest level of response differentiating drug liraglutide from control, which to me means that the whole concept of weight loss and potentially using GLPs might be, it potentiates therapies that patients are already on rather than being used as independent therapies. And finally, the most recent study that we have, and the first with sort of the modern use of GLP-1s, is semaglutide in obese patients with psoriasis who are on metformin already with poor diabetic control. But in these patients, you showed some very significant PASI improvements. And you can look at the median values in both cases, and you see some real responses in these patients, and they're not on other psoriatic therapies, suggesting to me that there is something here. But again, these are studies that are fraught with difficulty, and studies like the one Joe showed at the end, looking at the Lilly study looking at tirzepatide with ixekizumab might be the best way to go longer term and higher numbers of patients. So in conclusion, to stay on time, after researching literature, I can say I still have no fundamental understanding of whether we really can count on incretin therapy as being independently beneficial in psoriasis. I believe that the literature really points out that weight loss is good for obese patients, and incretins help that and significant value overall health. And I also think weight loss does have value with response to therapy in psoriasis. The data of independent addition of incretin therapy may depend on if patient's diabetic or not diabetic. And I think we have to think about that as a possibility, and that will have to be sub-evaluated in multiple studies going forward. The greatest value is an adjuvant therapy to other therapies. But really, what's missing here? You're on long-term, we're talking about incretin therapy as long-term treatment. Could there be value in blocking the development or the worsening of psoriasis? Could there be value in longer term that we don't see in these short-term 12 to 16-week studies? And so I think this is an area that's going to take a lot of investment and a lot of large studies to truly understand, but we're not there yet. With that, I say thank you very much.
That was wonderful, Ken. Thank you so much. Mostly on time. So it gives me great pleasure to introduce immediate past president of GRAPPA, Dr. April Armstrong, also chief at UCLA, possibly one of the folks with the highest normal intelligence in the room, who's going to discuss artificial intelligence with us now. April, thank you very much.
Thank you, Joe. Hello, everyone. I'm going to dive right into it. So today I'm going to talk about artificial intelligence in psoriasis, what the field looks like. And no matter how you feel about artificial intelligence, hopefully you can take a bit of nugget of this with you today. Here are my disclosures. So today we're going to talk about AI in psoriasis in terms of evaluating psoriasis severity.